co-founder of the Together Association, and it's really wonderful to have you all with us this evening. We've got a fantastic group of speakers, a panel that is going to do what we don't think at Together we have enough of in society currently, which is going to have a grown-up Together Association, and it's really wonderful to have you all with us this evening. We've got a fantastic group of speakers, a panel that is going to do what we don't think at Together we have. Right. Can you hear me still?
Yeah. Yeah. Yes.
I think someone was not muted. So yeah, if we keep everyone muted. So sorry about that, guys. One of those technical moments. We're going to have a debate, a grown-up debate with people who think very different things about the issue of assisted dying, and we're going to get into the tricky and thorny areas around it, and we're going to thrash them out, and then we're going to come out to some of you guys that are on the call and discuss this and come back again. Just to say that one of the things that we said it together all along is firstly our passion about free speech and debate and discussion. I think particularly now in light of what we've seen over the summer and subsequently, and even more recently with the questions around Alison Pearson and Maya Forstater, and even a 9-year-old who had a non-crime hate incident around calling another fellow pupil a name, that and the police getting involved in those things. And even today we've seen with Harry Miller from We Are Fair Cop, which we'll be doing something tomorrow on, so watch this space. I'll say at the end, the idea that we are able to discuss these things out with our fellow citizens, and actually the public citizens are grown up and can make decisions and discuss things and should be engaged with, and not just have things done, not have things done to them or to us, whether we happen to agree with them or not. But like that, we thrash them out and we look at what this means politically, morally, ethically, and that there's not been enough of that. And, you know, particularly in the last few years where so many things are happening and we were told it's the science or trust the experts or the evidence says this, that actually it's, you know, us often that have to make these decisions, and we need much more of that discussion and debate. So we're passionate about that. We're glad you're all here. I'm going to briefly introduce my panel this evening, but I will say to you that you can see some more about them on the site, and also you can read more about the themes on the site, which you will have done, I'm sure. But, you know, we've got some more detailed notes on the issues that you can look at. But I'm going to give you an abbreviated summary of them. They've kind of very, well, I say prestigious. They've got a lot of experience and highly, you know, decorated in their field. So we're going to have, and this is going to be in the order that they speak in. We're going to have first Professor Emeritus Sam Ahmedzai, who has spoken with us before, actually, but he's a British supportive and palliative care specialist. And an honorary consultant physician in palliative medicine. Speaking next will be Amanda Hunter, who's the Together Social Care chair in the cabinet and has campaigned against the abuse of end-of-life protocols. You will have seen her at Together doing that over the last period. Then we're going to have Dr. Steve James, who many of you will remember was actually working at King's College at the time when Sajid Javid was going around, and he actually addressed Sajid Javid at the time with concerns that he had. He's going to be talking about some of the practicalities. So he's not talking for or against the motion, whereas the other panelists are. But that will be quite useful for us to get a little bit of depth into that. And then we're also going to have Kevin Yuill. And Kevin is Emeritus Professor of History at Sunderland and is also an author of Assisted Suicide, the Liberal Humanist Case Against Legalization. And I'm very pleased to say that we've also got, which you won't have seen in the brief, we've also got Jackie Davis, who's joined us from Dignity in Dying. And it's really fantastic to have another speaker that's for the motion and the assisted dying bill, which, as we know, is going to be voted on the 29th in Parliament. And what we wanted to do this evening is to really get into the kind of discussion both hear for people for the motion and why they think this should become law, and those that are against, and for us to discuss it in light that, as I say, that we need to have many more of these conversations. And you'll see from the video that I did, like, you know, I just want to say this to start, because I think some people, some of our members and supporters, a few people have been concerned about maybe some of the language or some of the positioning. You know, I think that no one comes to this without feelings or emotions. I'm sure that many people, many of us certainly, have had firsthand experience with this, with family members and people around. And it's like, you know, a very emotive and a very sensitive question. I think in many ways, that's why it's so important that we are able to discuss it. But it, you know, it's something that has become politicized. That wasn't a choice together, but you know, so that's something that this whole debate in particular has really kicked up. So you know, as well as it being very deeply emotional for many people and sensitive, it is something that in the political sphere, in the public realm, we have to consider and discuss. So without further ado, I'm going to ask, because we only have a certain amount of time this evening, each panelist is going to speak for 6 minutes. After 5 minutes, I'm going to say you've 1 minute left, because we do want to be able to get questions and points from the people that are with us on the Zoom, and everyone that's at home that's watching and may want to send in a message. So let's start, please, with Sam. Thank you.
Thank you. Is my microphone on?
Yes, we can hear you. Thanks, Sam.
Thank you very much. Well, thank you very much for this opportunity to speak with you all tonight. You said I was an emeritus professor.
Thank you.
Did everyone put themselves on mute? Rob, can you mute everyone, please, except for Sam? And can everyone, Alia, yeah, and everyone, please. Sorry about that, Sam.
Yeah, sorry. As you introduced me, Alan, I'm an emeritus professor, which means I'm retired now. But before I retired from clinical practice, I had 30 years experience as a consultant in palliative medicine. I was in hospice for 9 years, and then in hospital and as a university professor for 21 years. I suppose I could be seen as a pillar of the palliative medicine establishment, because I was, after all, I was a founder of the Association of Palliative Medicine and the new specialty in the 1980s. I'm also acknowledged to be a leading expert on cancer-related pain. That's the science behind it, the state of the art in treatments. But also I am aware of the limitations of palliative and end-of-life care to adequately control pain and suffering for some people. Gradually, while I was working, I became increasingly skeptical about some of the weaknesses and failings of my specialty. In 2010, I was invited to join Lord Faulkner's Commission on Assisted Dying. They sent me to Oregon to see how it was done successfully there. In 2012, the Faulkner Commission published its report recommending a change in the law to legalize assisted dying. That's my background, but tonight I've got 3 arguments. First, people tell me, if end-of-life care ain't broke, Sam, why fix it? Well, the answer is yes, it is broke. A bit like the curate's egg, at least in parts. Let's start off with the scandal of the Liverpool Care Pathway. It started off as a reasonable idea in the 1990s to offer hospice-class care to people in their last days of life in every hospital and all other settings across the UK. The LCP was endorsed by the Royal Colleges, the NHS, and of course by the hospice and palliative care movement as an inexpensive and simple solution for care of the dying. But things went badly sour. In fact, the Liverpool Care Pathway story was a classic example of a slippery slope. The LCP ran ahead of itself without any underpinning research, with inadequate training and little accountability, and ultimately led to hundreds, if not thousands, of people having one-size-fits-all, unpleasant and undignified deaths imposed on them, often without their or their family's knowledge or consent. In 2013, the Liverpool Care Pathway was scrutinised and heavily criticised by an independent commission led by Baroness Neuberger. I was asked to give evidence to that commission, as I was already known to be a sceptic about the LCP. The LCP was abolished by Parliament in 2014. Now, 9 years later, Last year, in 2023, I was a co-author of a report commissioned by a parliamentary group on the state of end-of-life care based on real-life case studies. Our report was called When End-of-Life Care Goes Wrong. A senior barrister and I scrutinized 17 deaths from 2012 until 2021, and we documented harrowing experiences of people in hospitals, in hospice care, and in the community. 8 of the 17 had gone into hospital with an acute illness or for planned surgery that were not even for end-of-life care. Many of the modes of death we studied for this report were identical to what I had witnessed a decade ago under the Liverpool Care Pathway. And wait for this, 4 of the 17 people died under hospice care. If you need any more proof about the patchy and often woeful state of British palliative and end-of-life care, look at recent reports from the Care Quality Commission and from NICE and the National Audit for Care at the End of Life. These clearly show that palliative care in the UK, even after 50 years, is not always the gold standard that it wants the public to believe it is. My second point is, wouldn't increasing the amount of palliative care be better than allowing assisted dying? Well, frankly, from someone who's dedicated 30 years as a consultant in palliative care and a further 10 years in examining it, no. Let me tell you why. On average, a person is referred to palliative care services in their last days and weeks of life. Now, specialist palliative care is still, after 70 years of the hospice movement and specialized palliative care, almost exclusively for cancer patients. I'm talking 70 to 80% cancer patients. And important though it is, cancer only accounts for a quarter of all deaths. Over my career, a few patients with a variety of conditions have asked my team and me to end their life because of the symptoms that they were currently suffering in spite of our best efforts, or that they fear new and distressing symptoms such as breathlessness, like suffocation, horrific blood loss from throat cancer, vomiting up feces from bowel obstruction from bowel cancer. They knew they were dying. We told them, after all. So why did they have to wait till nature took its course? Some other patients wanted an earlier end because of the degrading indignities that they were suffering right now in spite of the best nursing care.
1 minute.
I can tell you that even if we ever get to afford and legislate for universal specialized palliative care for all terminal conditions, not just cancer, sorry, it's not going to happen. We can't even afford right now to have timely and life-saving oncology services for all cancer patients, never mind for all patients with heart, lung, kidney, stroke, or whatever. The next point is that people say, allowing assisted dying will lead to unintended consequences like the slippery slope and the problem of coercion. Now, don't get me started again on slippery slope. I've told you what happened with the Liverpool Care Pathway. But what about vulnerable people and their coercion? Well, let me tell you that people are being coerced in broad daylight into things like agreeing to a do not attempt resuscitation, DNR order. At least 2 of the cases that the legal expert and I reviewed for the parliamentary report last year had DNR orders placed on them against their and their families' wishes when their medical condition was eminently suitable for resuscitation. Hey, one of them was even a man aged 47 who was on a kidney transplant list. He died. In real life, patients are being coerced. That is, encouraged to reevaluate their lives and agree to stop cancer treatment, to stop having blood transfusions, and to have their feeding tubes taken out by well-meaning palliative care professionals who still follow the idealistic vision of a dying patient with no drips, tubes, or antibiotics. But taking those away means that those comfort treatments are just stopped, even without consent. Same goes for disabled people. One of the members of the Faulkner Commission was a long-term disabled person, and he would have wished to have assisted dying should he ever have a terminal condition.
That's great, man. Sorry, if you go like last bit, but we've run over a little bit. If you want to do the last little point, if you've got it, otherwise we'll come back to you in the point questions.
Okay, well, look, I'm happy to stop there. I can come back to the points.
Thank you very much.
I was just concluding.
Lots of really important things and things to think about there. Thank you, Sam. Amanda, please. Amanda Hunter.
Yeah, good evening, everyone. I'm not going to actually address the bill itself and the contents and the safeguards. Maybe that's something we can discuss later. I really want to look at the broader question of assisted suicide, or dying, as it's euphemistically called. So, I mean, I think that the speed and manner in which the terminally ill adults end of life bill is hurtling through Parliament should give us all cause for concern. This is not the way for any new legislation to be introduced, far less legislation that will have profound and potentially dangerous consequences. Such is our concern at the proposals currently before Parliament, and on which MPs will vote on November the 29th, that we are calling for a national referendum on assisted dying to be held before any decision is taken. We believe that the proposal to introduce assisted dying legislation in the UK is a matter of such fundamental import to the future of our nation and to us as citizens that it must be decided as a nation and not solely by members of Parliament. We also believe that the bill currently before Parliament requires far more scrutiny and time for deliberation than will be afforded by a private member's bill, as is the case in this instance. We strongly believe that both our members of Parliament and we, the public, must be given the opportunity to reflect upon the implications of the proposed legislation and the issue of assisted suicide more generally. Leaving aside the moral and ethical considerations, there are very considerable practical implications that need to be examined and discussed before a rational and reasoned decision can be taken on the issue. As it stands, there appears to be a poor understanding among MPs and the public as to what assisted dying means, what it entails, how it differs from palliative care, and the relevance of the economic, political, cultural context in which it would be exercised. And that's what I'm mainly going to talk about. Now that the contents of the bill have been finally published, and with just 9 days to go before the vote in Parliament, it's imperative that we understand what's at stake here and why the assurances provided in the text of the bill require far greater scrutiny than that offered thus far by the largely supportive media. Before reflecting on the details of the bill itself, I believe it would be useful to explore the reasons why we believe that assisted dying legislation in principle is wrong. There are many reasons why we should reject the proposals, but rather than focus on the moral and ethical considerations, the worrying trends in Canada and other countries where it's been introduced, and the slippery slope arguments favoured by campaigners opposed to assisted dying, we believe there are stronger arguments to be made, ones premised on deeply worrying trends far closer to home. These trends are economic, political, and cultural, and without a full understanding of their impact on society and the NHS more specifically, it's impossible to reach an informed decision about the merits of introducing assisted dying here in the UK. Nor can any reasoned decision be made without examining and reflecting upon the legacy of NHS treatment protocols, such as the livable care pathway that Sam has already detailed and the problems with it, but also those introduced during the COVID public health emergency, namely NICE guidance protocols NG 163 and NG 191, all of which set dangerous precedents in the treatment of the elderly and otherwise frail, and have very significant implications regarding how assisted dying would be used and potentially abused. Let's look at some of those trends. Economic. Despite some limited post-lockdown recovery, our economy remains sluggish. As it stands, the UK economic growth is insufficient to meet the needs of the growing health and social care needs of its population, and at the same time, resources are being diverted elsewhere. It does not require giant leaps of the imagination to envisage elderly and otherwise frail patients being coerced into considering the option of assisted suicide as an alternative to languishing in hospital beds for months on end, waiting home care packages or care home places, or to burdening themselves on their families when the long-awaited care fails to materialise. We must face facts. The NHS is broken. Due to its inability to bring down waiting lists and meet the increasing demands placed upon it, our National Health Service is already rationing care and denying patients equal access to treatment, favouring the under 65s over those of pensionable age. Patients who are not terminally ill and not actively dying, and Sam mentioned some of the cases that he looked at, are routinely being denied beneficial treatment on the basis of their age and their frailties, real or perceived. My own mother was one of them. And the other thing that I'd like to talk about, and sorry, just one thing on the protocols. I mean, Sam mentioned the end of when end-of-life care goes wrong in the report that revealed that the livable care pathway is very much still active, in practice. And further evidence emerged during the Scottish COVID inquiry, health and care impact hearings, with families and care home staff providing witness accounts of residents being denied access to GPs, denied antibiotics for infections, and being prescribed end-of-life drugs instead, as also happened in Scottish hospitals. But these practices continue. The precedents have been set, and they are being driven by rationing and the blanket use of end-of-life protocols. The increasing protocolization of medicine is a serious concern, with decisions with whose life is worth saving increasingly driven by age, clinical frailty scores, and narrowly defined perceptions of quality of life, rather than on a considered assessment of the individual patient and their potential to recover. Assisted suicide legislation would further expand the use of these protocols, providing cover for unscrupulous staff to coerce the vulnerable into accepting assisted death. As Sam talked about DNRs and the abuse of DNRs is very much a problem, and I can only see that this would get worse. So the NHS is already effectively assisting the deaths of the elderly and infirm, and very often it is people who are not actively dying, people who wish to live, who value life, and do not want to be helped along their way to save the NHS resources, yet find themselves hastened along end-of-life care pathways, regardless, without their consent or that of their families. I have digressed here, but deliberately so, as I feel it's imperative in the light of this assisted dying bill shortly to be debated in Parliament that the public are fully cognizant with the facts of NHS rationing, the denial of treatment to older and otherwise vulnerable patients, the protocolization of medicine, and the ongoing abuse of end-of-life protocols. And finally, this brings me to the cultural context in which assisted dying would be exercised. One of our greatest concerns at Together Social Care is the increasing ageism both within the NHS and across society generally. We're becoming increasingly ageist in our attitudes towards elderly population, viewing our senior citizens as economically inactive and a drain on what are deemed to be limited or finite resources. In the context of economic decline and a rapidly aging population, utilitarian notions around optimal resource allocation are creeping into public discourse. There is a very fine line to be drawn between utilitarian efficiency and eugenics, and we believe this is something we should be wise to consider when contemplating the introduction of assisted suicide. Now I'll finish there.
Thank you, Amanda. So, Steve, Dr. Steve James, I had a fascinating conversation with you, and I'd asked you to talk a bit about some of your practical experiences. I mean, just to say that in this conversation, and some people may be being shrill, or some people are just pointing to concerns they have. Some people will say, look, we've obviously got pain medication, but as Sam has said, palliative care, maybe it's not enough in certain instances, and we should be more humane. Others are saying, well, look at Canada. They said, don't look at the slippery soap case, but we can already see what's happened there. We've got real concerns. If you think about the last 4 years, some of the things we saw happening, not just in the livable care pathway that Sam's referred to, but also during COVID with do not resuscitate, DNARs and other measures. How much of this debate do you think is overly excitable? How much of it is all a question and concern for us? How do you see it on a practical day-to-day basis, Steve?
Okay, so the way I see it is you've got let's say a position statement on a medical treatment or intervention, and you want to ask yourself, is that roughly aligned with where society wants that to be. I think what we need to acknowledge is that at either end, mistakes are made. Yeah. So there'll be people who potentially get too much palliative care, should we say, and get a medicine that might shorten the end of their life. We wouldn't say that we shouldn't have palliative care because it might shorten people's lives. We think that we can generally deliver it well, and there will be some people who don't get palliative care at the right time, but we don't say don't do it. Yeah. With a DNAR, while undoubtedly people have that decision made inappropriately, what I see as a critical care consultant is junior doctors and teams not making enough DNAR decisions because they don't want to take that responsibility anymore to say it would not be appropriate to attempt resuscitation in the event of a cardiac arrest of this person. And it's a frequent review on the ward to see a patient and think as a critical care consultant, why on earth are we being asked to see this person? Why hasn't the team taken responsibility and asked the questions about this patient's prior functional status, wishes, expectations, where they're going to go? And I see junior doctors and also consultants now not prepared to make the decision for a DNAR often enough, much more often than I see a DNAR that I think is inappropriate. Okay, so I would say at both ends of a spectrum, you're getting that guidance, people are getting that guidance wrong.
And what about the question of the NHS and resource and the fact that we need all these beds, we don't have enough, we've got that conversation. You can imagine an accountant going, and the conversation of the environment. We've got perhaps too many people on the planet, people have outlived their uses, sometimes quite stark the way these things are discussed. How do you see those things impacting some of these decisions?
So essentially, I see that currently we are in a position where we offer, at least in our critical care, we offer to treat people the way they want to be treated. Okay, so I don't decide that we should stop treatment for patient X. I listen to the family and hear what they think that person would want under those circumstances, and try to offer whatever I can that would be fitting in the context of that patient. Okay, and I expect that people with different cultural backgrounds, etc., and just different life stories will have different wishes. What that means, though, is that as a society, we spend incredible amounts of our fairly limited resources according to what people wish. Now, I think that a lot of my colleagues think that we end up, by respecting the individual's wish, spending an awful lot of money on some people for really what we in our eyes see as a relatively small benefit. So if you have, if you're in a comatose state and you're 65 and your family says you would want to stay on and live forever, even without any kind of really potential signs, it might be argued that if you've expressed that you'd want to keep on living because you're able to move your fingers a little bit, that we should respect that wish. Yeah. And we have to say to ourselves as doctors, really, how are we helping people by offering them this? And because people are in hospital, they get hope and they think that some magic miracle is going to happen, and a vast amount of resources go into this. Now, we're not really in a position of having that discussion to say, hang on, is that really a good place to do it? Because we know that with the same amount of money, we essentially could provide better care for other people in a way that most of the population would say that's better.
Okay, so just on the last sort of point, and we're going to come back to all of you, but just on this, we did, however, and it may have been different at King's, but we did see over the lockdown years a number of things happen. When we sometimes have the free speech argument, people say, "Oh yeah, but you're exaggerating the concerns of what might happen with free speech." You say, and I suppose a lot of people have seen a lot of these things firsthand already. Sam's talked about some of the problems already with the livable care pathway. What are the measures in the context of this? If there's going to be legislative decisions and implementations of law, how then isn't that like after the horse is bolted? So what,
So two things there.
Yeah.
COVID was essentially your rights being removed.
Yeah.
Yeah. And this bill is essentially saying whether it's done in the right way or not, you've got a bit more right to decide yourself. Okay. So that was things being taken away. This is essentially rights being given to people. Now, what we're worried about is those rights being given to people who maybe don't have those rights and they're being abuses or things like that. The second thing is about it being a private member's bill. And there's discussion about whether that's the right thing. The vote on the 29th is not going to put it onto the statute books. Yeah, it's the first reading. It's still got to go through a lot of processes of Parliament. And usually with private members' bills, unless they have really quite widespread support, they don't make it. Okay, so the fact that it is a private members' bill means it's not being pushed through by the government. It means that there is the opportunity for, if there's not an agreement amongst MPs, chances are it won't get enough time, it won't make the hurdles it would need to make, and it won't come through. But the Abortion Act in 1967, that came through as a private member's bill. And we don't think that, we're not really currently in a state of debate to say that that was rushed through Parliament and that's terrible. Now, you can have your opinions about the abortion bill, but because it's a private member's bill doesn't mean it's not going to get enough hearing. Yeah? It could not get enough hearing. Yeah? Many things could happen. Yeah? But just because it's going through that process doesn't mean it won't get enough scrutiny or it won't have to pass enough hurdles.
Right.
So from my point, I would say really, do we need to give some more people the opportunity to choose and have self-determination in this situation? I think we need a bit more of that. Now, I think there are ways to go about getting there, but I don't see there's a particular obstacle at this stage to say, no, we absolutely shouldn't go forwards.
Okay, thanks. That's been very clear. Thank you, Steve, for that. So I'm going to ask Jackie Davis now to speak from Dignity in Dying. Over to you, Jackie, please.
Thanks for asking me. Just a bit about my background. I've been a doctor all my professional life, and I've been campaigning for assisted dying for the last 10 years. I've been asked why, and I would say I've seen a lot of suffering in my professional lifetime, both professionally and in my own family, of course. And, you know, Alan said at the beginning, you're all of, he said many members it'll resonate. Why? Why do so many of us have had the experience of bad deaths in our family? And that's why I campaign. One bad death is one bad death too many, and we know that they're happening out there. So can we do it in this country? You know, 300 million people around the world have access to assisted dying. So please don't tell me we can't do as well as they do. Possibly Sam and I are the only people who've been to Oregon to see what goes on over there. But I really wish that people who are against the law would go and talk to the people in different countries where this is happening, because I can tell you all the things that everybody is worried about just don't happen. And people will tell you it works. It's been going for 25 years in Oregon. It's still less than 1% of deaths. And there's never been any enlargement of the legislation. There's never been any attempt to push it back. So we don't have to cast around looking for all sorts of things that we're worried about, because other people have faced this and they have dealt with it, and they've dealt with it successfully. And going to Oregon would tell everybody that. I just want to address some of the things that we've heard this evening, arguments against, which of course we're all very familiar with. The coercion argument. Well, I went to a meeting in Parliament last week where Sam was there listening to doctors from countries in which this is happening. We heard California, Australia. The only coercion they see is the coercion of families trying to get their loved ones not to go down the assisted dying pathway, but to hang on a little bit longer. That's the only coercion that they describe. We hear a lot about vulnerable people and the disabled. There's no evidence whatsoever in Oregon or any other country where this has happened that these people are, and in fact, the only way you can get an assisted death if you're disabled or elderly is to be terminally ill. And interestingly, the only people who've complained about the Oregon law is a group of disabled people who said, because we're disabled, we can't administer the medication. So that's as far as it goes with disabled people. We've heard about costs. West treating has been so disgraceful, I'm sorry to say. Ministers were told to stay out of this. They've all been really discreet about it. I heard one of them on the radio this morning. Streeting has weaponized the NHS, and it's been absolutely disgraceful. The civil servants in Scotland have done cost analysis on this because their bill is further ahead. It would be cost neutral. And the fact is, it would be vanishingly small numbers of people. We know that. It's 0.6% of deaths in Oregon. It's not going to be many people. And the other important point about that is these people are in the health system already. They're not suddenly being imported in and costing money. They are in the system already. So it's nonsense to say it's going to cost a lot of money, and disgraceful to say that services are going to be cut because of that. Let's talk about Canada. We're not going to get the Canadian law. Opponents love it, but we're not going to get the Canadian law because it's a completely different setup there. The courts can tell Parliament what to do. That's what happened. That's why things have changed over there. People love to talk about slippery slopes, but the Health Select Committee who looked at assisted dying said there has been no slippery slope in any of the countries with the Oregon model. And of course, that's the one we're looking at. No slippery slope at all. And nobody calling for it to be reversed because it works. Just to address a couple of other things, we've heard about we can have a referendum. We know what will happen if there's a referendum. We know that between 70 and 80% of the population support legislation. That's right across the board. I gave evidence in Jersey when they had a citizens' jury down there. And what was interesting was that they spent a long time listening to evidence from both sides. And at the end of it, the jury that they'd chosen, random people in Jersey, actually went for a law that was more extreme than the one that we're looking at after they'd heard all the evidence. So when people tell you, oh, when people find out about it, they don't want it, I'm sorry, that's simply not true. Rushed? No, I'm saying this has been around for years. And as my colleague said, your private members' bills are absolutely the classic way to bring in these big social changes. So, abortion had to come in that way, the legalization of homosexuality, the abolition of the death penalty. It's a very, very good way to do it. It's been drafted by a very experienced person. And as he said, this isn't set in stone. If it gets through its second reading, it will then go to committee stage and be really examined very carefully. So I don't know how much time I've left, but I just want to do a little balancing thing here. On the one hand, we know what we've got. Are you shaking your head? Have I got 1 minute?
No, you go for it. Go for it. You've got some time. You've got about 1.5 minutes. That's
okay,
fine.
Good. Okay. We know what we've got on one hand. On one hand, we've got people suffering every day. We've all seen bad deaths, and that's terrible. And Sam is nodding his head. He knows. He's the guy on the front line who sees these things. And I have too in a professional lifetime, who cannot be reached by the best palliative care. And you add to that pile of people up to 600 people every year who commit suicide, take their own lives while they're terminally ill. And I had that happen in my family. Not only terrible for the person who takes their own life, but absolutely dreadful for the family they leave behind. And you've got the one person a week who can afford to go to Dignitas, £15,000, thank you very much, and have to go before they're ready to die because they have to be able to travel on their own because they can't take their family with them. So it's a huge pile of suffering on this side. Excuse me, I need to stop for a drink of water. I'm sorry, I've got a cold at the moment. My throat's going. Imagine, if you will, all these sad people on this side. On this side, we've got concerns, absolutely understand them, about coercion, about the vulnerable, and all the rest of it. But we know from other countries that will not happen. We won't get the Canada law. The law you pass is the law you get. We won't get Belgium or Holland or any of those places. So on this side, we've got theoretical concerns that haven't happened in other countries. On this side, we've really got a pile of suffering people. And I can tell you one thing, that in all the public discussions I've had about this, I have never heard from opponents of assisted dying what they're offering, this huge pile of people on this side, because their concerns are here and they've got nothing to offer these people here. I just will finish by saying that, unfortunately, I'm not talking about anybody here tonight, but I am making, after a decade of talking about this, a lot of the opposition to this is faith-based. It's very difficult to deal with that because it's not rational. And in our secular society, people cannot say, I believe that God doesn't like this. But I know, because I do a lot of public debate about this, that a lot of what we hear from opponents is faith-based, and in front of that are put the straw men of the vulnerable and the disabled and coercion, when there is absolutely no evidence of that from where this is happening already. So in conclusion, it doesn't work in this country. It can't go on as it is. We've got all the suffering that nobody's addressing. And if it doesn't happen this time, it's going to have to happen in the future, because we've got Scotland, Jersey, Isle of Man, Spain, Portugal, France. We're going to be an island of suffering in the middle of all these people who have adopted assisted dying. Sorry, my voice has given up. Thank you very much.
Well, no, you've made your case very eloquently. Thank you very much, Dr. Jackie Davis. And then finally now, Kevin Yuill, please.
Hope you feel better, Jackie. I'm going to make 2 points. First of all, the bill is deeply suspect, and I don't think, even if I was in favor of it, and I'm really not, of assisted dying, that I could vote for it. And I think there'll be a lot of people that won't. The second point I'm going to make is that we now have evidence to show how problematic assisted suicide will be when it is actually, if it is actually put through. So first, a preliminary point, assisted dying or assisted suicide, what should we say? Let me ask you, if somebody shoots themselves in the head, would you call that suicide? If a doctor hands a patient a rope and that patient hangs herself, would that be assisted suicide? If a doctor hands a patient deadly drugs, knowing he would use them to end his life, is that suddenly magically assisted dying? No, we're being manipulated. We're being gaslighted with this whole discussion. What we're discussing and what the bill discusses is suicide. And we should be honest before we even have this discussion, I feel. First of all, okay, so the bill is a mess. We've heard that. Sam Coates from, neutrals have said the bill is a mess. Sam Coates said no impact assessment until and unless the legislation passes second reading. And it is actually second reading, Steve, rather than first reading that's coming up on the 29th. The first reading is just the title. This is second reading. So MPs will be engaging in one of the most totemic votes of this parliament without access to all the facts and being asked to commit to partial information. And this bill has been brought with just over 2 weeks for MPs to completely familiarize themselves with a 38-page document that it begs as many questions as it answers. So here are the specifics. It doesn't prevent doctors from proposing assisted suicide to patients. So that's actually in the bill, that they can bring it up. Now, this in Canada, I can assure you, has created huge amounts of difficulty, including a woman who is about to have breast cancer treatment, being asked, well, have you considered assisted suicide, or as they call it there, MAID, medical assistance in dying? That happened to her twice. These are documented cases. There are many, many undocumented cases going on with this. So that's a problem. It doesn't allow doctors to opt out of discussing either assisted suicide or to refer patients to doctors who will do it. Again, this has created difficulties in Canada, where in Nova Scotia, 25 doctors resigned because they did not want to be part of this whole process. Not only that, but we know from polling that patients do not want doctors who are killing patients. It's the majority of people in a particular poll I'm thinking of from June 2024 said that they did not want their doctor to opt into this program if it's passed. I don't think, it would undermine the doctor-patient relationship, I feel, or further undermine it. person who can have treatment that relieves their symptoms would still be eligible. There's no mentioning of suffering in the bill at all, which is interesting. But the way it's worded, it would include people with type 1 diabetes or anorexia or arthritis. These are possible in the wording of the bill as it is now. This is what it includes. The doctor can, quote, assist the person to take the drugs, but not to cause death. Yes, do you think maybe there's some reason to worry about that's actually problematic? And there's no requirement to monitor doctors' assessments, and there's a use of a proxy to sign the form if the patient cannot. And that, I feel, is open to abuse in a big, big way. It legalizes assisted suicide for patients whose death can be reasonably expected within 6 months, but doctors are notoriously bad at months. It's easier to tell when somebody has weeks left to live, but you cannot, most doctors, according to the studies I've read, cannot successfully predict a 6-month life expectancy. They get it wrong as often as they get it right. So that is also a problem. So the Secretary of State must ensure that assisted suicide is available. Interestingly, there's no such duty to provide patients palliative care to everyone who needs it. And I think that's very problematic. So on to the evidence. What evidence have we got? We've got evidence, I've been writing about this for 25 years, and we've got a lot more evidence then. And sadly, what I predicted has come true. So rather than the scenario of the loving family surrounding someone who takes a potion and passes peacefully out of this world, avoiding the messiness and unpredictability of life and death, it is too often a young woman whose anorexia has destroyed her hope in the rest of her life, and whose doctor agrees and euthanizes her. It's too often a young man with autism who finds it difficult to make social connections and has no friends, so his doctor gave him a lethal injection. This is the reality of what the evidence from around the world shows. These, of course, are not common scenarios. I'm not going to argue that they are. The most common scenario that will come is, if this bill is passed, is that of CO2s who chose assisted suicide in Australia rather than a 10-month wait for live-in care. And that's what's going to happen if we pass this bill. We're going to have many poor, elderly, ill people with very, very few options actually going for this. While, when we already have prejudice against the old, the ill, and the disabled, as the COVID debacle showed, whereby those with mental disabilities were deprioritized, despite the fact that they had just as much, just as good a prognosis for getting rid of COVID. They were deprioritized, and I think introducing assisted suicide into this, such a heady situation is really problematic. Many of you will have examples whereby your relatives face neglect to the point that they die. Do you really trust the present system to implement assisted suicide and trust it to deliver it in any kind of way? We need a health service that helps those who need it. Those at the bottom of society, the rich and the poor, the ill and well, anybody who needs the health service should be able to get it. And it's not so much coercion, it's pressure. People, elderly people, feel they don't want to feel a burden. So, that's going to be not so much coercion. Nobody's coercing them, but they will pressure themselves. They will feel that pressure, whereby they are told, you know what, you're in a category that is open to assisted suicide. And that's one of your treatment options. And any good doctor will give all of the treatment options. That's another problem with this bill. What's the person going to say? Okay, sorry, Alan, last sentence. We need a health service that helps those at the bottom as well as the top. We don't want to prioritize the bespoke celebrity deaths over what the poor and ill will suffer.
Okay, thank you very much.
Thanks.
I want to ask a couple of questions. I'm going to ask the silly questions because I feel like they're always a good way to get down to things. And then I'm going to ask each of you something, and then we're going to get out to everyone else to ask some questions. But my first one is about palliative care, because it keeps coming up. And I just want to understand what you all think about this, because I don't want to put words in anyone's mouth. Sam, you talked about this, so I want to come to you first. What are you arguing? Are you arguing that if palliative care was done properly and better, that this would be less of a conversation we'd be having, it wouldn't be so needed, or you would still be in support of it? What's your exact point about palliative care, just so I can understand it, we will understand it clearly?
Thank you. Several points. Firstly, palliative care is very choosy. From its inception, it's focused only on advanced stage cancer, people who are only in the last weeks of life, and maybe a few neurological conditions. It excludes discriminatorily a lot of other conditions where people will be know that they're dying. Palliative care, no matter how much of it there is, you will get variation. Can we be honest and say not everybody is good at palliative care? We know there are variations in the quality of healthcare given by even qualified people. And we've seen examples of that in our parliamentary report last year, where people were from palliative care doing dastardly things. So even just having more palliative care doesn't mean to say everybody will get good care. And lastly, there are limits to what we can do. We cannot, and I am an expert in pain, cancer-related pain. I know I cannot manage every case of severe pain without putting the patient to sleep, basically, which is not
okay. So can I ask you though, what makes you think that if it's uneven, the distribution of palliative care, and not everyone can do it well or properly, why will everyone be able to do theoretically anything else well or properly or diligently or fairly? What like end of life, increasing that more speedily?
Right. Very good question, Alan. And I can tell you it's there in the bill. Right now, there is no bill legislating how palliative care should be delivered. And there are no legal, sort of sanctions on bad palliative care. The bill criminalizes people who are misusing the act. The bill actually has safeguards built in, which would be wonderful if we had some of those in palliative care.
Yeah. Amanda, how do you buy the argument that because a lot of people comment on the post that we make about this, that palliative care is almost non-existent for some people, or it's not good enough, or it's not invested enough? How much is that an issue and a concern of yours? Would that redress this balance, or is that missing the point, the fundamental point from your point of view?
No, I think you're right. It's available, as Sam said, to very few people. I think it's something like 30% who only 30% actually have access to it, of those who would benefit from it. And I think it is a real problem that we don't have sufficient palliative care, and they are woefully underfunded. And remarkably, Stephen Kinnock yesterday, the Minister for Palliative Care himself, saw that there was no conflict between the absence of sufficient palliative care, which he must know about, and assisted dying. One wonders if he's the right man for the job. I think that the argument we should be making is for a far better economy, that we can actually invest far more in our NHS and palliative care services. We are getting older as a nation. We have more comorbidities. We need more help at end of life. And I certainly don't agree with Steve James, who seems to think that we should be siphoning off resources and dedicating those to the young, because we can help them a bit more than the elderly have as much right to access to care and treatment as the young. And also, they have paid into the system for years, and now they're being abandoned. It's wrong.
Okay, so Jackie, you were shaking your head when Kevin was speaking, but I want to ask you a question that I've struggled with, which is recently a very good friend of mine, his mother was, he was told that his mother needs to go. They need to put her onto this end of life pathway. and that she had a very short amount of time to live. And, you know, he fought this. And if you've got an advocate, it seems to me, and whether it's in A&E or anywhere else, who's articulate and not the person who's having this done to them, which is obviously the circumstances are very different, then they can be your champion and things can be different. But this was 14 months ago and she's living a really happy, good life now. And so what does in this bill, this question about 6 months, as well as other things, like you said that these concerns are overblown, but, you know, the slippery soap arguments and others. But it is the case in the bill at the moment, as it stands, that you do need that a doctor can suggest it to someone who's not considering it. That's not considered coercion. It's considered just a doctor saying it to you. But how do you see this question of the 6 months thing, for instance? Do we ever know it's going to be 6 months? Is it going to be 12? Is it going to be 18? Is it going to be 2? Just some thoughts on that, if you would.
Yeah, thanks. There's a number of things I'd like to address very quickly, but that prognosis one is really important. The 6 months is an arbitrary thing, but firstly, doctors tend to overestimate prognosis. So actually, people tend to live. This is statistical fact that people tend to live less long than their doctors think they're going to. The second thing is the people who are involved in looking at an assisted death are not suicidal. Kevin and other people insist on talking about assisted suicide. There was a young woman in California, Brittany Maynard, who was diagnosed with a brain tumor. She was young, she just got married, she was told she was going to die with it. And she did a lot of blogging, and she said something that I think is really helpful. She said, "I don't want to die, but I'm dying." And that is the situation with these people. They don't want to die, but they're dying. So they're not suicidal, they don't want to die. And if they take the medication, and of course many of them won't, even though they inquire about it, they will take it right at the end if and when things become intolerable. So it doesn't matter if you're given a prognosis of 6 months or a year or whatever, you will, statistically, we know this, you will not take that medication until right at the end. So it doesn't matter if you're told it was 6 months and you live 7 months. I just addressed the suicidal thing, and the families of people who take assisted death really don't like people talking about suicide because it's pejorative, and so it's much kinder to talk about assisted dying.
One more point. And then...
I just want to pick up something else he said about the doctor-patient relationship. We know that the doctor-patient relationship improves when assisted dying is available, because patients can then have that conversation with doctors that they can't have now. Most of them will not go on to have an assisted death, but the BMA did a big survey, biggest survey done in this country, and patients said actually it would improve their relationship with their doctors. So I'm afraid it's simply wrong to say that. And all those scenarios about autism and all the rest of it, let's dump that, because let's talk about Canada. We're not going to get Canada. And those are egregious examples anyway.
Okay, thank you, Jackie. So that really leads me on very timely to Steve James. The question of autism actually has just come up recently with Stephen Jackson, a lawyer with Law or Fiction, where someone who had autism and someone who had Down syndrome, who was actually made unconscious, and then injected with a jab that they did not want, that their family did not want, but the people around them thought that they should have it. Now, they were not, that was a jab that they were given. But I suppose it raises the question that you were saying, Steve, that this is about choice. And people having their choice, rather than like during COVID and lockdowns where choices were taken away. But we have seen all sorts of discussions, haven't we? Like too many people, perhaps people not being productive anymore. What are these concerns about, you know, the Malthusian ones about the planet? We know that the questions about the NHS beds and resources is a constant one that we're always discussing. So just with those two things and what you've heard and what's in the bill, does that not concern you? Do you think they're not legitimate concerns? Do you think that's being overblown? Or just how do you see that, Steve? Steve James, I think you got your mute.
Yeah, hi.
Hi, thanks.
Yeah, I'm happy to hear people express concerns. I think, you know, debate and hearing opinions that are contrary to what you would come out with is a good sign in society, and then we can listen to all those things and we can hear which voices most convincing, and then we can hopefully decide or get change made in a country that's representative of what people actually want. If we weren't concerned about something like a bill like this having gone through COVID, it would be very strange. Yeah, if everybody had their head in the sand and said, "Oh, this will be wonderful. We totally trust parliamentarians to do everything right because they've done everything so well for so long," that would be odd. That would be strange if we didn't do that. But if we don't think that anything good can be done through Parliament going forwards, we're also in a terrible situation. So you've got to still got to look, but with open eyes at the situation. Just want to address something that Amanda raised. This is not about ageism. When I mentioned a 65-year-old, I'm not talking about a person who's old. I'm talking about a person who's young. I'm talking about a person who's got many, many years to live. I see these patients on intensive care who are very young, who are very old. We do not treat them differently, other than the fact that we know that some young bodies recover faster or have greater potential to recover than older bodies, in particular when it comes to brains. So there's really no decision making now based on age. In my experience, in my critical care, I'm sure there's ageism going on in other parts of the country. But the way we are treating people is about what's their individual wishes, what's their potential, what fits for those people. Yeah. And someone who themselves wants to live longer because they want to live longer, that's what's relevant, not their age. You have to take into account their ability to benefit from treatment based on their biological age, not on their sort of chronological age. But that's it's a very much more non-ageist approach that we have now compared with when I started in medicine 25 years ago, when people who were over 80 wouldn't be considered for intensive care. I treated numerous patients who were in their 80s or 90s on intensive care. Things have shifted in the right direction.
Okay. I mean, we should just add a caveat to that people are saying that if you drink or smoke too much or perhaps eat the wrong foods, perhaps you should not be the first in line, and you might be a little bit further down the line. But
Alan, quickly on that. We must not have a healthcare system that says we can attribute to you responsibility and therefore you're not entitled to care.
Yeah.
Right? That's a very, very dangerous place to be.
It is indeed.
Right? It's really, really dangerous.
Yeah, those points are being argued and made, but you've made that point well. So just because we're going to need to get to the audience, but Kevin, I want to throw something back at you. Okay, people talk about MAID and Canada, people talk about the Netherlands, but many are talking about Oregon. People that people that are in the same political party that are split on this issue, and it's a free bill, even though there has been some whipping, but it's a free bill and people are making their own decisions, but they're pointing to Oregon. Now, what would you say? Some people might say, Kevin, you're being overly alarmist. What's the proportion of people in Oregon this really goes to? Is this just a kind of overblown concern? And is it, and I know you've got concerns about this, is it just that there's a deficit in trust now with politicians, with the medical practitioners? Is that really what's going on, that people just lack trust and we think everyone's going to do terrible things? How would you argue? What's your argument against this bill? You've been clear about some of the concerns you have, but with the Oregon model versus, say, Canada and others, just so we get your take on that.
Well, yes. First of all, on Canada began with what was called a reasonably foreseeable death, which meant de facto with a terminal illness. Then they started that in 2016. In 2020, they moved the goalpost. Well, it was effective in 2021, and they said that basically anybody with a chronic condition, which is de facto not all disabled people, but somebody with a permanent disability and a chronic condition, then was able to have euthanasia. I should say that in Canada, euthanasia is more the thing than assisted suicide. But so Canada did start with terminal illness, and then it spread. And in 2027, it's going to all people with mental illnesses as well. So they will qualify. In Oregon, Oregon does have it's a small percentage of the people that take it. It's a small population, to be absolutely honest, in Oregon. But Jackie's wrong to say that it hasn't enlarged, because it's enlarged twice. It's enlarged in 2020 and 2023. It changed the law in both those situations. One was to allow out-of-state people to come in, and the other was to allow those to reduce the waiting period from 15 days right down to 48 hours. So it's wrong to say it just hasn't enlarged, because it has. And in answer to your question, Alan, I mean, I think they keep very, very terrible records in Oregon, and which is a problem. But what we do know is that there have been deaths for anorexia in Oregon, because it's what's called terminal anorexia has been diagnosed. And this is one of the problems when you look at the Scottish bill that people are talking about in the chat room, and look at the bill here, and you see that what they're talking about, terminal illness suddenly becomes expensive, and more things can become a terminal illness. So I think that's the way it's expanding in Oregon. But it's necessary to see what's happened in other countries as well. I think the Netherlands and Belgium are also relevant to this whole discussion.
Okay, thank you very much. We've got lots of people who want to speak. I'm going to start with, and if you could bring your camera on, if you can, with Eileen Chubb first, then we've got David, then Peter. So Eileen, please.
Oh, can you hear me?
Yes, we can.
Oh, sorry, I think my camera's gone off. Yeah, I can only speak from the evidence of all of those vulnerable people whose suffering is not heard. It's invisible. We've supported 14,000 whistleblowers on our helpline, and every day these staff have to fight for people's lives, where food is withdrawn, where drink is withdrawn, where basic care is withdrawn. I founded this charity as a result of my own experience in care. In the first hour I went into a care home, I tweeted on this yesterday, for example, there was an old lady laying on a bed, no covers on, and both the windows were wide open, and it was November. And I said, oh, that lady's cold. And I was told she's in her 90s, we're trying to speed things up. That is the norm that, you know, we hear about every hour of every day. And since I tweeted that yesterday, we've been contacted by 360 care staff saying that they had similar experiences. And when they raised it, they lost their job. So the reality is this kind of abuse of vulnerable people in care homes is going on every hour of every day, but we do not hear about it. Now, you're reliant on regulators to tell you if things are going to be overseen properly. We recently did a call for evidence on people's experiences of regulators. 28,000 people responded. One of those responses was positive. Most of every other response said that they raised serious concerns about the care of a loved one, or they were whistleblowers raising concerns, and no action was taken whatsoever. So this is the climate that is the reality for vulnerable people. And whilst many people might say there's no evidence that this might affect vulnerable people, in care homes, people are already playing God with people's lives. They are withdrawing food and drink, and we're worried the message that this will send out to those people.
Right. You made that point very well. Thank you, Eileen. So then we've got David Payton, please.
Thank you, Alan. I just wanted to pick up the point about the more subtle pressure that vulnerable people can feel when these laws are passed. And that's really goes to the heart of the problem with assisted suicide, and it is assisted suicide, not assisted dying. We do have evidence from Oregon, which has been mentioned a lot. They ask patients who die what their concerns are about end of life, in their end of life, and why they're choosing assisted suicide. We know over 40% of patients say it's because they're worried about being a burden on family, friends, and carers, and that proportion has increased very significantly since it was legalized in Oregon. And that's going to be made particularly bad by the law in this country, which they're proposing, where doctors are allowed to raise the issue with patients. That's going to increase these people in very, very vulnerable positions. And I think we need to remember why we have laws that do not allow us to help people commit suicide, even though we may have sympathy with those who wish to end their lives. The reason is to protect vulnerable people. That's why we have laws that say we're never allowed to help people to end their lives, even if they've asked us to. These laws protect vulnerable people, and we're going to really cross a Rubicon if we allow assisted dying to happen in this country.
Okay, thank you, David. So Peter Adams next, please.
Thank you. My point is the bit about 2 doctors required to actually sign the form, and getting 2 of them to agree that somebody's going to die within 6 months, as we've heard before. There's lots of people who struggle on beyond that. But the other thing is about getting a judge to sign it. Why are we going through this process? If you look over the past 4 or 5 years, all the cases where the doctors have brought the case to the High Court or judges, the judges always agree with the medics. There are cases there where people were given the opportunity to be taken various other places and get treatment. Okay, the treatment might not have worked, but it gave the people hope that they could actually do it. In some cases, it might have got cut, but the judge will always agree with the doctor. So why have they bothered putting that in the act?
Okay, good question. So then next we've got Clive Morris, then Liz. After that, please, Liz Evans. Are you with us, Clive? Right, we'll take Liz first, please, and then we'll see what's happening. Liz Evans, thank you.
Hi, Alan. Just for clarity, I run the UK Medical Freedom Alliance. We are an organisation that campaign on medical ethics. So informed consent, first do no harm. And obviously, I'm quite interested that none of the doctors have actually mentioned medical ethics, because this would turn medical ethics completely on its head. It's really interesting, even in the Hippocratic Oath, where I think there is a huge wisdom and recognises that you need to have a very clear boundary around medical care, because it is a situation where there's a fundamental imbalance of power between a doctor who has the power and the knowledge and the patient who's in a vulnerable position. So that's why we have to practice medicine within clear ethical frameworks to avoid any abuse occurring. And in the original Hippocratic Oath, it actually said that a doctor must never administer or attempt to procure a medication to harm somebody or to end their life. So I think there's been a recognition that euthanasia is probably not a great thing to bring into medicine. But on the point of informed consent, I worry that people are not actually informed as to what this death will look like. So the bill's very clear. It is suicide in the sense that suicide means taking your own life at your own hand. The doctor cannot, with this bill, actually administer any medication. But there is no guarantee that this death will be quick or painless. And in fact, I was reading a paper of the Association of Anesthesiologists or Anaesthetists, and there's quite a high incidence of vomiting after these drugs, which are unregulated. There's no sort of set concoction. There's no, different countries use different cocktails. People react really differently to drugs. So you may get a quick, swift death. But about a third of these deaths take between 90 minutes and 30 hours. And according to the bill, if you're following the bill, the doctor is not allowed to step in to help you if things start to go wrong, because they are then colluding. I mean, I haven't had a lawyer say to me that is not the case. So reading the law at the moment, it looks like you're on your own once you take those pills or that concoction. And if something goes wrong, if you're unconscious, then come round. If you are in pain or if you're suffocating and you can't cope, the doctor can't help. Whereas in a hospital, if you were, having palliative care and your pain or your breathing difficulties get worse, the doctors are able to give you help with morphine. So I think we have to have informed consent around what this death actually looks like. I think it will always be a violent act to take your own life. And I think to try to pretend that in a clinical environment that is, you can kind of sanitize death is naive.
Okay, Liz, thank you very much for that contribution. So there was someone else who wanted to speak, but I've got Nicola Curtin, and then maybe the gentleman that was trying to speak can come back in. And do have your hand up if you can't work out how to do it on here. Then we'll have Clive after that. So we'll have Nicola, then Clive, and then there'll be any more, and then I'm going to bring back the speakers. Great. So Nicola, please.
Hi, hello. I'm up here in Scotland, so I feel as though you need to be outside of a situation, like you're I think you're all in England, right? So you're inside the forest, which means you can't see everything, all the parts of this issue, you can only see it from maybe up above or outside, and I'm viewing this, I am deeply, deeply, deeply concerned that people might think this is a good thing. This will stop people suffering and doing the caring thing. But we have a prime minister who is pursuing an agenda of genocide, around the world, So what makes people here or anywhere else think, oh, he's going to bring this in a compassionate way? No, this, in my view, this is bringing in the death penalty via other means, just not calling it the death penalty. And I do not trust a single word as an approach any sensible person would take. I do not trust a single word that comes out of the mouth of that monster called Starmer. Remember, he used to be a member of, possibly he still is, of the Trilateral Commission, who are pursuing an agenda of depopulation. And this, to me, could be a part of that. So be very, very careful that he's known for also twisting the facts. He has denied things. There is video evidence of him saying it on television, that he approves of, that he supports Israel being allowed to deny all the life essentials, to Palestinians that we all need to survive. So and he goes around now denying that he ever said it, but you can bring it up in video anytime you like, where he said that to, I think it was Nick Ferrari. Be very, very careful that if he gets word or anybody gets word that you assisted someone to die, thinking you're doing the compassionate thing, he could then twist the facts and accuse you of murder. Has anybody ever thought of that? This is deeply, deeply worrying for me.
Okay, thank you, Nicola. And then we've got Clive.
Hi. Yeah.
Hi. Yes. Hi, Clive.
Can you hear me?
Yes, can hear you loud and clear. Thanks.
Good. Yeah. I mean, I've got a letter in today's Metro about assisted dying, which I'm quite pleased to get in. I don't print everything I write. And it's response to another letter writer. And I'll paraphrase it because I think you're fed up with hearing people read things out verbatim. But generally, the other guy on Monday was talking about how his mum had a terrible time in hospital. She was suffering. She was screaming in agony. And why can't we have a bill like this? And I gave reference to my mother, who was perfectly all right for 3.5 years. She nearly died in a care home. Nobody's ever held to account. She was put on end-of-life care without any consultation with us. You've no idea the number of tricks and tactics they play. And this is Surrey County Council, to get you onto this. They seem to be working in conjunction with the NHS Trust. But my sister and I had to go into the care home daily. We had to take it in turns to give her a drink. And it didn't actually twig with me that they just weren't giving her a drink because she was on end-of-life care. I just thought it was one of those strange, neglectful things. I thought it might be because they wanted to save money on incontinence pants. And it took me a while to realise that they were being passive aggressive. They were, and this was started in 2014. And because we went in to give her a drink, we kept her going, or we stopped them killing her. And she died in October 2017. So it's a similar experience to your other contributor, Amanda Hunter, who got on the case with her mum, and she saw her out, and it was 3.5 years. But the fact is, your parents' untimely death saves the state money, and that is what it's about. They don't want to spend money on pensions and prescriptions, and when they die, they get a nice inheritance tax. And I will point out also, we were self-funding, so we were paying around £1,000 a week to go into the care home to give our mum drink. We had to fight, in a way, with the care home, in as much as if we ever raised any suggestion as to why they weren't giving drink, there was counter moves against us of the sort of tricks and tactics I'm sure Eileen Chubb would be familiar with. They accuse you of all sorts of things, of being a safeguarding hazard yourself and all this. They know what they're doing. And this has been going on now for a decade. And I think they got her in the end, but it was in the end. You know, eventually she really was in the situation where she wasn't getting much out of life. She was on a peg feed, and you know, the checklist was satisfied in the end. But they can do what they want if they don't really have to consult with the family. If they didn't get lasting power of attorney in health and welfare, they can do as they please. If you don't have LPA, you can't read the medical notes. So on the medical notes, they can make out your parent is in a far worse state than they actually are. They can sort of doctor everything, no pun intended. So, I mean, that's why a lot of us are opposed to this, is because we've seen that actually, forget the slippery slope, it's the black run, and it's been going on. You know, we might as well be in the chalet knocking back the après-ski, you know, the martinis. It's been happening. So you can understand our worry that someone's introducing a bill, which normally I would support, but they're introducing a bill that, like the Liverpool Care Pathway, can be interpreted whatever way they like. Because, I mean, I don't agree with much with your previous contributor and her hatred of Keir Starmer, but I do agree with her in that you don't trust a damn thing with this state, whether it's the Met Police or the contaminated blood scandal or anything to do with, you know, Postmaster Generals. There's so many scandals where you only find out what's going on 30 years down the line. We are not in a situation where anyone can be trusted passing this law. But my fear, just to sign off on this, is that what you see in this chat is that the people who are pro this bill have a certain solidarity, and I'm not sure that the some of us who are talking against it really have that kind of solidarity. It's like the Tolstoy quote, you know, unhappy families are unhappy in their different ways. Where you get a bunch of people who are in favour of this bill, and they'll all agree with each other, and there's a likelihood that all those who are against it start falling out among themselves. It's just the way, I'm afraid.
Okay, Clive, thank you for that. I'm going to come back to the panel now. One of the things I'd like to say is leading on from that, really, but is how would you address this concern? I mean, many people have experience with people in care homes. We've seen not just that we lost 45,000 care workers during the lockdown period, but that everybody agrees, regardless of their political opinions, that there's massively under-resourced, as well as problems that we see in the NHS. The whole discussion about resource. What's the argument to really that these cost-cutting, resource-making, issue-solving things will not happen? What is it? Just a hope that people are just really ethical? Is it a hope that doctors would never do anything like that? Because I can see the situation with someone with a spreadsheet going, well, you know, really forget it. You know, I'm a bean counter, and we see some of these things happen, but the quick way to deal with some of our resources is that. Why is that not the case? Why is that, you know, are these checks and measures really strong enough? The question about 2 doctors, And if the second one doesn't agree, you can go and you can keep finding a second one that does agree. Are we going to have ambulance chasing style doctors that do this type of thing and just specialize in this area? Is that an overblown concern? And I suppose the question is, and in each of those, whatever point you want to take up and respond to, when people talk about burden issues and concerns, so the cultural thing, as well as the slippery slope, what's the argument that those things will not happen? I mean, it'd be good if all of you could respond to that, because it's a question that often comes up. I've just seen that Jan Bowman's got a hand up. Very quickly, Jan, because we need to finish up now. But if you can quickly make your point, and then we'll go to the speakers. Thanks.
I don't know if you can see me. Can you hear me?
Yes, we can. Yes.
It seems to me that surely we can't trust the state stroke the NHS to act humanely, and that we need to trust each other and ourselves and have more democracy on this. And I think we need to focus on, surely a humane system would be focusing on social care, far more funding for social care and integration of social care and hospital care, and have social care run by the community, not run by the state. Far more democracy in social care. Secondly, a friend told me who was dying of cancer that she had a whole stack of pills upstairs given to her by the hospital for if she wanted to go early. I don't understand why. It seems to me, why can't we leave our moral compass as it is in the law, whereby we value human life in principle, all human life in principle, and discourage suicide and euthanasia and the creeping devaluation of human life, and leave it as a private matter between the patient and the doctor, which is what it's been, forever kind of thing. Yeah, so that's my point.
Thank you, Jan. Right, so, as ever, we're never going to get enough time to thrash all of this out in the way it really should be, and we can come back again. But I'd like to invite Sam to come back to us, please. And this is going to be short. We've only got a couple of minutes, so you can take any of those issues and just to sum up your point and why people should take your position, Sam.
Goodness, I don't know where to start. Firstly, to Kevin, please don't bring up issues about people with anorexia and all these various other conditions. They are absolutely not in the remit of this bill. It is only for terminally ill people. So that's a red herring. Regarding sorry, I can't remember the main point you wanted to make. What was the main question you wanted?
Well,
to
I think the question is how the against the slippery slope or burden. Are the measures so robust to prevent that? What is it? Are we being a bit too concerned?
Alan, the evidence from the countries apart from Canada, apart from Belgium and the Netherlands, is that their slippery slope does not exist. Yes, there may have been a slight changes tinkering to the bill in Oregon, but just to make it easier for those who were going to get it anyway, shortening the time, slippery slope does not exist. So just again, a misapprehension. I think basically what I'm trying to say is that would you rather trust the medical nursing fraternity to make decisions on every sort of terminally ill patient, and we've heard about cases where it goes terribly wrong, or would you rather have a system which is actually legislated for? Right now, there's a possibility of having legislation and criminalizing bad behavior. A lot of things we've heard about that went wrong were actually probably criminal negligence, malpractice. And some of us, including me, are trying to actually get those cases to court. It's not a case of, it's just either palliative care or advanced assisted dying. You can have very good palliative care. If it's not good enough, then prosecute, then identify those ones which have gone off the rails, but then also make assisted dying available. In the jurisdictions where it's available, the two work beautifully hand in hand, and practitioners can swap from one to the other.
Okay, thank you, Sam. Amanda, please.
Yeah, well, I think we can safely say that the coercion is already within the system. I mean, we've seen that with the DNARs. And coming back to Steve James on that, this idea that DNARs are only about resuscitation, unfortunately, they're not now. Post-COVID, DNARs are often used to decline treatment. not just not intervene with, resuscitation. The other thing is, I think we have to be really honest here. People are saying there's no slippery slope. I think we can see that that has happened in every country where this law has been introduced. There's been a gradual extension of the categories of suffering, and that will happen. And the other thing is, those who claim that only Parliament will have the power to determine changes in the scope and practice of assisted suicide ignore the fact that change is not determined by laws alone, but happens organically and incrementally within society. It is evidence from the legacy of the Liverpool Care Pathway, whose practices continue despite it being officially banned, that culture has a habit of driving practice irrespective of the law. Once we cross this Rubicon, as we did with the Liverpool Care Pathway, that is the end. And I really am very concerned about what awaits us if we do.
Thank you, Amanda. Steve, I'm going to give you a chance to just say a couple of things. I know you're not, like, you weren't arguing for or against it, but just having heard the case here, if I push you a bit, where would you stand on it, or anything you want to say, Steve James?
I think he's gone.
Oh, is he gone? All right, he's got out of that one. Okay, so in which case, let's have Jackie, please.
Yeah, thanks very much. I just want to say, we've heard an extraordinary amount of concern this evening about what goes on, in care homes and all the rest of it. That's exactly why we need this law, because it's absolutely the most safeguarded law in the world. No other assisted dying law in the world has a judicial intervention. And so the person who said, why do we need it? Because people are worried about coercion. And that's why the judge would come in and make sure there was no coercion. It wouldn't be a rubber stamping thing. And that is the whole point of this. It's safeguards. One of your other speakers said, oh, let's just have this between the patient and the doctor. I'm afraid Shipman put an end to that. And these things that go on behind closed doors are much worse than having a safeguarded law with two doctors and a judge up at the front. There was talk about the Hippocratic Oath. We no longer take the Hippocratic Oath. We take the Declaration of Geneva. And the Declaration of Geneva says, put the patient first. And the same speaker, Amanda, spoke about the imbalance of power. The imbalance of power shows itself at the end of life when medical paternalism suddenly comes out and says, you can't have the choice that you want. And that is the imbalance of power at the end of life. I'm afraid we heard some very wrong things about what happens with death in Oregon. I've been there, so has Sam. I've spoken to the people who actually do this. The average time to unconsciousness is between 10 and 20 minutes. The average time to death is about an hour. These egregious examples that we heard about are with people who have problems with their gastrointestinal tract. They can't absorb things properly, and there are other ways of dealing it. These deaths are not what has been described, which is terrible, choking, and all the rest of it. Those are the deaths that people are facing without an assisted death. And interestingly, in summary, I described the figures here, the people we know are suffering, and the theoretical concerns that none of our opponents, and we have a lot of them here tonight, have actually said what you're going to do about the people who are suffering every day, and palliative care and all the rest of it aren't going to help them. Well, apparently we're just going to let them go on suffering, and I think that's unacceptable. Thank you.
Okay, thank you very much, Jackie. And then Kevin, please.
Right, well, I'm going to start by agreeing with Jackie on something, which is odd. Jackie said one bad death is one bad death too many. But then she blithely dismissed the fact that one bad death in Oregon took 137 hours. I mean, if this were capital punishment, everybody would be up in arms about this. But because it's at the end of life, people don't seem to be that concerned. Also, on the slippery slope, it's worth noting that 54 MPs have already said that the bill doesn't go far enough. So if anybody thinks that they're going to go home after the bill is passed, I think you're absolutely wrong. I think it's going to happen. So I think, and just to reply to Sam, anorexia has happened in Oregon. I can point you to a study that shows 60 cases around the world, 100% women. interestingly, most of them young women, who have suffered anorexia, and that includes the United States. And in the wording of the bill, it allows that. You can bring yourself to terminal anorexia. You will be terminally ill if you continue starving yourself. You can bring yourself to that. So I think it is a worry, and I think it has happened in various other countries. I think yes, one of the interesting arguments is that we've had 10 years to discuss this. So we don't need to discuss it for longer than 2 weeks. And then people point out difficulties with the bill. Well, we can do something about that later. We've got plenty of time after second reading. And you kind of think, well, choose a side there, which is it? You've had 10 years to concoct a bloody bill, and you've got this pile of crap. I'm sorry, but read it. I encourage everybody to read it and see what you actually think about it, because it's not great at all. I want to finish on resource issues, which is the question that Alan asked, which I think is absolutely right to highlight, because I think in the end, it will come down to resource issues. And the real problem here that everybody needs to take into account is that assisted death is cheaper than palliative care. It's worth about one assisted death costs about 1 week of palliative care. So I don't want to live in a country, particularly, that prioritizes money above human beings. I think that is the definition of uncivilized country. I think a civilized country cares about its elderly, about its ill, and it treats people the same, no matter what stage of life they are in. And I think that's the real problem, is that always when this has been brought up, and I'm a historian, so I know these things, since 1870, it was always brought up with two things. First of all, compassion, which I admit is motivates people on the other side, but it always is about money as well, and utility. How useful is this person to society has been the judge of who gets this and who doesn't. And I don't think that's the right way to live.
Okay, thank you, Kevin. So I want to thank you all for these contributions. I would also say as well, Jackie said earlier that, if you have a referendum, it is already clear that everyone will go a certain way. The point that together is really about why we really formed was so that we wouldn't just have things done to us, that we'd be able to have a say, that the public will be able to have our voices made and heard, we'd be engaged with properly, we'd look at costs and benefits, we'd weigh things up, and we'd exercise our judgment. And it's in that spirit that we're having this discussion, and that we're asking everyone to contact their MPs and say, we need more time. People need to hear these discussions and thrash them out. We can make decisions. And contrary to some of the discussion in Britain, where they said everyone was stupid or was lied to or couldn't quite work out whether they knew what their interest was for the last referendum, where there's a kind of contemptuous notion of the stupid people, that people can make decisions, and they and are able to work out what they think and make political and moral and ethical decisions. And sometimes one may lose an argument and a battle democratically, but you thrash it out and you have it out, and that's the important thing. And so we're saying we'd love you all to contact your MPs. We've already been doing calls to action to do that, and to say that in this instance you should vote no against it, because we haven't had enough time. It's sufficient. The bill only just came out. It's 38 pages. It has a number of issues that we've talked about on the site, and some people have talked about it here today. And that if something's really that important to have, or if everyone really believes in it, then it's really worth being able to thrash it out and discuss it and understand all the nuances and points. There's a number of things we haven't talked about tonight. Like sometimes people think they would like to do something in the future, and then they may change their minds. I would just say, on a practical point, when you have a power of attorney, you should be lodging it with the Office of Public Guardian as well. People have come into all sorts of issues when people have decisions. Those decisions are important in families to discuss and thrash out and to write down and make it all clear. But this is a discussion not just about personally and privately. You may make all sorts of decisions in that context, but publicly and for society, what that means for everyone. And we are very concerned at Together that in the last few years, particularly, all sorts of things have been said. We've been told we have to save or protect the NHS. We've been told that you have to do some things because these people are saying it. We've been told that we should shut up because we're not doctors or scientists. And we're concerned about those things, even whilst we recognize and understand that many really diligent and passionate and compassionate and caring people are working and frontline staff, medical profession and elsewhere. So that's the backdrop to all of this. As ever, we could talk about this much more. We would like to see a referendum. We're going to argue for that. But right now, we're asking you to contact your MPs. And right now, we shouldn't get a knock on the door for saying this and doing this. But we are seeing increasingly that everything from non-crime hate incidents to people being saying that you're not allowed to say things because they're hateful are happening. We've seen that happen with, as I said at the start, Alison Pearson and others. And we've just seen that Harry Miller was called into the police station for an article he wrote in The Critic. He has arrested the sergeant when he went in for harassment. We'll be doing a stream with Harry tomorrow at 1 p.m. We invite everyone to come along to that. Keir Starmer had said he'd urged police chiefs to stop policing tweets and start policing without fear or favour. He didn't say without fear or favour. I think many people are concerned about two-tier policing, two-tier judiciary. Speaks to many of the concerns that the British public have at the moment. I will just say as well, we've seen remarkable thing happen with the public recently with the farmers and what happened yesterday and ongoing. And I think it's an exciting moment that we can have these kinds of debates and discussions. I know some people get very shrill, but I think that in the spirit of what we're doing it together, we want to hear our opponents. We don't want to censor them and shut them down. We don't want them cancelled. We don't want anyone cancelled. We think we're big enough to hear these things and discuss them. And we hope that, we're convinced that the antiseptic of light will shine on things that are bad ideas or wrong ideas, or maybe even ideas that are not bad or wrong, but we just don't agree with and we want to win our fellow citizens to. Because in the end, we're always better together. We're fellow citizens. You're not evil if you disagree with one another, but we do need to win hearts and minds, and that's what we're all about. So join us tomorrow. Thank you very much to the panelists. I really appreciate you joining us and being willing to come out and discuss these things. Please do become a member if you're not a member at Together. That's how we carry on campaigning. Become a signatory. And get some people involved with us because we're always better and stronger together. Thank you.
Thank you. That was brilliant.
Thanks, Alan. Thanks, everyone. Thanks, all the panel.
Thank you, guys.
Thank you.
Thank you.
Brilliant.
Thanks, everybody, for
Great
their
discussion.
contributions.
Thank you.
Thank you.
Thank you very
More.
much.
Thanks, Amanda.
More discussion.
Thanks for a grown-up discussion.
Thank you,
Yes.
Sam, for coming. Really appreciate it.